about how to tackle a difficult abdominal, incisional, or ventral hernia. This is something that I've spent a lot of time working on over the last 12 years, and I think that we've made some advances in minimally invasive approaches to successful ventral, incisional, and abdominal hernia repairs. As I wrote in our recent paper, we've gradually developed and refined a technique for minimally invasive surgical repair of complex and recurrent hernias through use of stay sutures, transfascial anchoring sutures, and mesh material that has qualities that make it ideal for repairing difficult hernias. That being that it is softer and produces less pain and symptoms, but is also strong and provides durable long-term, hopefully lifelong support for the hernia repair. Our technique has been one of attempting, whenever possible, to perform a laparoscopic or a minimally invasive approach to the hernia repair. This involves small incisions that are generally made off to the side of the abdomen, and that affords us a nice view into the abdominal cavity. Oftentimes this requires some lysis of the adhesions within the abdominal cavity. This so-called adhesiolysis has to be done very carefully by an experienced surgeon to make sure there's no intestinal injury that occurs as a result of that procedure. Next, the mesh material is chosen for its size and matches the hernia defect. It's important that we achieve a good overlap beyond the fascial defect or the rim of the tissue that forms the hernia. And a good 3 centimeter defect is considered good, and ideal maybe a bit more than that perhaps. Looking at the abdominal wall then, we choose sites generally for 4 north, south, east, and west anchoring transfascial sutures, and these will be placed all the way through the abdominal wall layers and down through the mesh material itself, and brought up and anchor it into the perfect position so that it is symmetrical and ideally oriented. So first the mesh is rolled into position, soaked in some antibiotic solution, and placed within the abdominal cavity, brought up to cover the hernia defect, moved precisely into position, and then secured with these transfascial anchoring sutures at the north, south, east, and west corners or edges of the mesh. Lastly, we use a tacking device, and in recent years absorbable tacker materials have been used, and that allows us to secure the mesh to the abdominal wall tissues firmly and circumferentially around the hernia area. Those tacks or suture-like materials gradually dissolve over the course of many months as the mesh material becomes incorporated within the abdominal wall and muscular tissue. We then can take a nice examination and look and see that the hernia is successfully repaired before removing our trocars and closing. What this results in then is a very successful and very durable repair, and one that we think is better in many ways than the conventional open repairs, because we have had such a good view, such good visualization of exactly where our mesh material is and how well it is covering the hernia defect. It's also anchored and secured much more successfully and firmly than we often have done historically with open conventional hernia repairs. But yet it offers those advantages while not requiring an open abdominal operation that requires a long recovery time due to the pain and the healing of the wound or incisions. So it really does represent, I think, an advance forward in the treatment of ventral, abdominal, and incisional hernias, and it's a technique that I think will continue to evolve, but that we have brought forward to be very successful in treating what can be a very challenging condition.